Hi, everyone. Welcome back to Clinicians Brief, the podcast, where we bring you the conversations behind our clinical content. I'm the host of this show, Dr. Alyssa Watson, and today we're talking about something that some clinicians absolutely thrive on, but others would very much prefer to avoid, and that is emergencies in general practice. So we all know that even if you don't work in a dedicated ER, those urgent, unpredictable cases still find their way onto your schedule, and it can be disruptive to your day. So joining me for this conversation is Dr. Kate Boatright. She's a small animal veterinarian, educator, and she's truly an advocate for mentorship, wellness, and realistic practice expectations. She's the author of a recent Clinicians Brief article titled Top 5 Tips for Managing Emergencies in General Practice. And I'm so excited she's here today to talk a little bit about her own experiences, as well as really share some insights on how do we stabilize some of these critical patients, how can we communicate clearly with our clients, and how can we build stronger relationships with our local ER teams so that when these emergencies happen, we're better prepared. Dr. Boatright, I know you've done some work for Clinicians Brief before, been in some roundtable discussions, but this is your first time on the podcast, and I just want to say welcome. We're so happy to have you here.
Yeah, it is so great to be here and, unlock another interaction with the fabulous team at Clinicians Brief.
Well, that's very kind of you. Before we jump into all of your pearls, would you just give us a quick little bio, tell us about your veterinary journey?
Yeah, so I do a little bit of everything. So work part-time in small animal practice. I'm a 2013 Penn grad, and I have been in rural practice since graduating, all small animal. But the closest I've ever worked to a specialty hospital is 45 minutes. My very first hospital was actually 4 hours from the closest specialty hospital. So I got a lot of hands-on first year out because we did not have specialists that, even if we have clients who could afford the specialty hospital, when you told them where it was, they're like, yeah, no, we'll just stay here. So I've worked in general practice. I've worked in a non-specialty emergency clinic. I've done some relief in ER and urgent care now. And I left full-time practice a few years back to really pursue my passion for mentorship and educating professionals. And my passion areas are mentorship and spectrum of care, and really equipping us as colleagues and teams to do as much as we can with the resources that we have.
Yep, I really love that. And your passion for that has shown through in previous discussions, and I'm sure it's going to be on display here today too. I'm the same way, never worked, well, I'm in Vegas now, so luckily we have a tertiary facility here. But before this, I was in Reno, and the closest place we had, was over in California. There's no teaching hospital in Nevada or anything like that. And so, yeah, lots of times you're making do with what you have in the area, and time as well as distance can really be a limiting factor for our clients. So, before we talk about these pearls that you have, I actually just kind of want to talk about the kinds of emergencies that we see commonly, and why do you think that these can be just so disruptive to our workflow?
Yeah, so I mean, I think there's a huge variety, and I think I would say the more common things that I'm seeing are going to be like your pyometra, foreign body, your blocked cats, things like that, and a lot of those, they're sick depending on how long it's been going on. They may be very sick, but a lot of times they are scheduled as, regular appointments. Maybe they're a same day appointment or something like that, but they're not necessarily the client calls in a panic, and is like, I'm on my way to the clinic. And you're like, I really don't want you to come.
Or sometimes doesn't even call and just walks through
Right.
the door.
Exactly. So and respiratory cases, I think, are a big one. I just had a crazy one yesterday that we'll talk about here in a bit. But I think it's less common that we're seeing some of those like critical, life threatening, like my dog was just hit by a car. or something like that. Although I earlier this year had 1 week where we had 3 hit by cars in 1 week. And so it happens, and we still have to be prepared for it. I think i think they're disruptive because, one, like, when we have those scheduled appointments, we know, we kind of know generally what we're doing, what to expect. And then, you get this extra thing that comes in, or the wellness appointment turns out that, hey, they've been vomiting for a few days. Actually, one of the foreign bodies that I cut this year was scheduled as a new puppy visit. When they came in, they're like, oh, yeah, he's been vomiting for like 24 hours pretty profusely. And my colleague, palpated the abdomen, was like, there's something weird in here. And ended up, so, owners thought they were coming in for puppy vaccines and ended up having their dog in exploratory surgery to remove a corn cob. And she did great. But, obviously with something like that, it's like, okay, well, now if we're adding in a surgery, we've got to find a doctor to do that. And I think the smaller the team, the more disruptive it is, because you've got to pull techs, you've got to pull doctors. Whereas, like, if you're in a larger hospital and, maybe there's a dedicated surgery doctor every day, hey, can we add one more into the schedule? We've already got techs assigned for that duty. And sometimes, there are times where I'm the only doctor in the building and I have something critical come in that I need to be with. Either my appointments that were scheduled are waiting, or we're talking to them about rescheduling.
Yep, we're going to talk about that, I think, after the break, really some of those key client communication points and how to have those conversations in order and still maintain trust, with the practice. But I'm just like you, when I'm in clinic these days, I also wear several different hats. And so, and I'm still in clinic occasionally. And when I am, it's usually just me, and so, yeah, just like you said, a PIO comes in, or, we're, like I said, Vegas. So heat stroke is one that we see, unfortunately, a lot, especially in the summertime here in Vegas. And yeah, oftentimes that means I'm shifting things around completely, trying to figure out how to stabilize these animals work so I can get them somewhere where they can have 24-hour care. Um, I know for me, when that happens, when that emergency walks in the door, or just like you said, you have something that was a routine, I mean, how many times have we had a routine or a appointment for just being off, and the animal comes in and it's pale and a fluid wave and you've got a, bleeding abdominal tumor. It can be really overwhelming. And so do you have any mindfulness techniques or kind of reminders that can help not only me as a clinician, but like our whole team? Like you said, sometimes we have a very small team, just shift into that ER mode.
I mean, I think it is just kind of, you know, stopping and saying, like, okay, yes, there are 2 patients waiting in exam rooms, but this patient in front of me needs all of my attention right now. Take a deep breath. In general, most of the things we're going to do are the same things we're doing in our routine appointments. We just maybe need to do them a little faster. Um, like, and also I really think being, like, from a team perspective, like saying, like, okay, like, let's be very clear and direct with our communication. Like, yeah, it may come off that I'm barking orders at you, but I just want to make, I'm not doing it meanly. I'm just being, hey, I need this, and this, and I need it now. And so I think that, you know, also remembering that, how we communicate in those situations with our team is so critical. And, usually, when I worked in the ER, you have something critical come in, those technicians are doing that every day, all the time. you know, Before you say, they've 6 technicians have already gathered all of the supplies that you need. Whereas when I'm in general practice, and, like, I did practice ER for a while, so I have the most experience ER background in our clinic. So, in my head, I'm like, I need this, and this. And my technicians know, they know to grab a catheter, they know to grab, certain things. but there are things that I might think of that aren't at the top of their head. And so just being very clear about, this is what we need right now. And then sometimes it is just, if you're an assistant or a kennel assistant, sometimes it is just like, stand by, like just stay close, because I might start yelling, hey, I need towels, I need, bring the ultrasound over, whatever that is. But it is very much like, okay, like, let's just focus on what's right here, don't worry about the other stuff. If they're stable, you know we can get to it when we can.
Right. And then that leads into really kind of my next question was, there's definitely different resources available in general practice compared to a dedicated ER, as well as, like you said, staff that doesn't experience that all the time, and even things like just their limited staffing hours. Our clinic closes at 6 o'clock. So how does that shape your kind of initial approach when you have a critical patient in front of you?
Yeah, so I mean, I think if they are physically in the building, then it's one, a lot of times when I'm talking to clients, I'm letting them know, like, hey, this is how far I can go, and anything beyond this, we're gonna have to send you elsewhere. And so just setting that expectation early, that like, I'm probably not going to be able to provide definitive treatment, but I can get your pet into a better place so that you can take it to where it needs to be. And I have some clients who, like, they're ready to run out the door, as soon as I say, like, you're going to need to go to the specialty hospital. They're like, okay, let's go. And I'm like, no, you don't want to leave with your pet next, like, right this second, because if you do, it's probably going to die on the way there. Like, give me, like, here's our goal. We need to get the bleeding stopped. We need to get your pet breathing in a better place. We want to make sure that there's some pain control on board. And so making sure that I think the biggest thing is just setting those expectations with clients. And remembering, we have the basics in general practice. You've got IV catheters, you've got fluids. Yes, we can debate about what the best fluid is for a given situation. But if you have a hypovolemic pet, the fluid that's on your shelf is the best fluid. So if all you have is 0.9% saline, like, no, I don't love bolusing it because it's more acidic. I'm worried more about electrolytes. But if that's what I have, and I have a dog that's hypovolemic, and it's different if they're 5 minutes away to get to the specialty hospital, but when they're an hour away, like, yeah, that dog needs some volume support. And so it's being, aware that, hey, this may not be by the book, medicine, but this is what, we can do to help the pet. And sometimes it is just calling down to the place where you're transferring them. I do that all the time. And I say, hey, this is what's going on. This is what I have available. What do you want me to do before I send them? And sometimes they say, oh, they sound pretty stable, just get them on the road. And other times they say, yeah, you need to do XYZ. And we'll go, they'll suggest something. I'll say, I don't have that drug here. Is there anything else I can do? I just learned yesterday you can give trazodone rectally to help with sedation. Never done that before. But, I had a patient with respiratory distress, and we ended up having to intubate. And we had the pet anesthetized, and we were breathing for it. And, talking to the criticalist, she's like, okay, and now you're going to want to give some trazodone rectally, so that gets in their system. And I'm like, hey, not something I would ever think of doing. So, our specialist colleagues and our ER doctors are huge assets to definitely have in those situations.
Yeah, we're absolutely going to talk about that a little bit too, and about some pointers for how to feel comfortable talking to them. But I agree with you. And you have to be pragmatic, and this is what we have. So we're going to figure out a way. Vets are very resourceful. we're MacGyvers. We're going to figure out a way to get it done. So yeah, you definitely, that's one of your first tips, start with this systematic approach, airways, breathing, circulation, get that all under control. Do you personally advocate for like team training on this, rehearsing this so that you're actually ready beforehand?
Yeah, I think that's a great thing to do, like as a team practice, because if I'm in an exam room when the critical pet comes in, like, if we know something is coming in and it sounds pretty critical, I'll have a, I'll be prepared, and I'll know to kind of be listening. We have a pretty small clinic, so usually, like, if I know to be listening for something coming in the door, I can hear it. But like most of the time I'm tuning out what's going on the other side of the exam room door, because I'm trying to focus on that client. So my team needs to know what to start assessing. Do they need to be grabbing oxygen? Do they need to be do they need to be running and getting me immediately, or can this wait for 2 minutes until I get out of the exam room? So making sure that, yeah, our teams are prepared for some of that basic triage, and knowing, here are the really important things that you need to assess.
Yeah. Um, Another thing that I have seen just with me over the years when I have that patient in crisis, I think it's only natural, not only for me as the clinician, but also my team, because they want to help, to try to gather, as much diagnostic information as possible really, really quickly. I have seen times where we've caused a lot of stress in patients by trying to get some of these diagnostics, though, trying to get x-rays. And so why is it so important to really step back and make sure that we stabilize these patients, even if that means maybe delaying some of these diagnostic procedures?
Yeah, well, I mean, the number one thing is because we don't want them to die in X-ray. Like, that is the one place in my hospital that I'm like, nothing should ever die in this room. Like, if they do, I've done something wrong. Or I way underestimated how sick they were. And so, making sure, that we also communicate the risks to owners and say, hey, like, we need to get this information. We think we have your pet in the best possible place to do it, but the stress of this diagnostic could worsen them. We could end up having them pass away. And sometimes too, it's not even the diagnostics, but it's like, I'm not doing, eyes and ears necessarily. Like, on a hit by car, yeah, I'm looking at the eyes to see if I've got, hemorrhage and things like that. But that's not my number one thing. That's after we got them stabilized. So making sure that, we are, that we're remembering that that triage exam is not meant to be a full physical. That is meant to make sure that they can get oxygen into their body, and they can get the oxygen from their lungs to the rest of their body. And just, I think sometimes, like you said, we get really focused on doing, like, because when they're stable, yeah, let's go get the x-rays, let's go get the blood work. But when they're critical, we have to step back and make some decisions sometimes without that diagnostic information.
Yeah. I do think that this is one place where you know, now that point of care ultrasound is a lot more accessible, it's more portable. I mean, we even have probes that attach to your phone and things like that, which is so nice. How have you integrated that into your initial assessment of these patients?
Yeah, so especially with like a trauma case, like a hit by car, I'm, doing that fast scan to check and see, like, okay, do I have, free fluid in the abdomen? I'm not as good with the thoracic fast scan. I'm working on it. But there's a lot of information we can get from those point of care ultrasounds as well. And so doing a little bit of training, if you have an ultrasound in your clinic, trying to find some CE on learn, hey, how can we best utilize this to assess these patients? If I'm worried, I can, by their breathing pattern, if I'm worried about pleural space disease, pop that ultrasound on and see if we're seeing fluid in the pleural space, or gas. And then I don't have to take an x-ray. I can say, hey, I can see that there is fluid here, and we need to address that before we roll this pet into x-ray.
Yeah. I think one thing that I started doing too, again, now that it's just much more accessible, I didn't have a lot of ultrasound training in school, and my first couple practices didn't have ultrasounds. Now, luckily, most of the practices, the clinics that I'm in do, but I stick it on everything that I can. So if I have an animal that's being
Mm-hmm.
spayed or something, I'm like, I'm just going to put this on and just look around so I can see what normal looks like. Because then when I'm in that situation, like you talked about, it's easier for me to recognize abnormal.
Yeah. Absolutely. Yeah, like I love, like when I was learning, I do, some basic ultrasound in the clinic. And when I was learning that, yeah, it was like, hey, this pet's here for a spay. Let's zoom around with the ultrasound probe for a few minutes before we do surgery. So that we can get used to it.
Yeah. And then there's obviously lots of other resources out there. What about things like emergency drug dose charts? How do those fit into your approach to just building team confidence and making sure we have something as simple as a fully stocked crash cart?
Yeah, I mean, I think it's really important. Like when you're in the moment and you have a pet that is crashing in front of you, I don't want to be sitting there with a calculator figuring out drug doses. And I don't know those doses off the top of my head. Like I would have to be pulling out, my plums or pulling out my phone and looking at the plums app. Like I don't know that off the top of my head. And so, having them in an easily accessible area, like in our clinic, we have them in surgery, but we also, I think having them in a treatment area is really good. For us, since surgery is where the oxygen is, if anything is coming in critical, a lot of times we're kind of taking them to that region, or our dental room, if surgery is in use, and getting them set up there. So we got that right, kind of where the patients are going. And then, in terms of a crash cart, when in the ERs, they've got these, huge carts that have, anything and everything you can think of. And that's great. You know, we don't have room for that in our general practice. And honestly, we're not, thankfully, and I'm going to knock on wood here because I am superstitious. We're not dealing with that on a regular basis. So, but I mean, even just getting like a tackle box or like a little toolbox and just stocking it with, syringes, catheters, tape, e-tubes, some of the basics that you might need, your atropine, epinephrine,
Mhm.
just having that and making sure that it's in a place that and then if you do have it, because it's not going to be something you're routinely using, making sure that you have a staff member who's in charge of checking to make sure, hey, have those drugs expired? Is there periodically, checking to make sure it's well stocked. If we use it, making sure it gets restocked, and so making sure that we're assigning that to a staff member, so that it's ready to go and we're not running around scrambling. And it's also really easy if you have someone who's new to the staff to say, you know, instead of saying, oh, I need this, 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 and this, it's go grab that box right there. And it's all here.
Yeah, I love that. Definitely has been a tackle box in multiple of my practices.
Yeah.
So. You're busy. Your CE needs to be easy to earn, and easy to track. Clinician's Brief CE is highly relevant and now more convenient than ever. Study online, from home, or on the go, and always at your own pace. Courses are RACE approved and designed with your busy schedule in mind. Start your next course today at cliniciansbrief.com/CE. Okay, we're going to shift gears just a little bit. Before the break, we talked about kind of the clinical side of stabilizing these patients. But I want to have a deeper conversation about communication, because there are a lot of people that you're talking to. We've already said you're talking to the staff. We're also talking to clients from our regular, day that are scheduled. We're also hopefully talking with the emergency department or referral center that we may be transferring to. So I want to talk more. We said a little bit, but just setting those expectations with the owner when they first come in, without really overwhelming them or alarming them.
Yeah. I mean, I think that one thing, and there's a fine line, like you said, like with like setting expectations, but not alarming them. I do think, and I think one of the things that we don't always are in the habit of in a GP setting is getting a CPR code, or a CPR orders, because it's like those seconds matter. And so if I have a pet that comes in, and it's just been hit by a car or it's in respiratory distress, making sure that, and then that's how I present it to clients and train my staff too, is to say like, you know, right now we're working to stabilize your pet. Because things can change quickly in these situations, we do like to know how you would want us to proceed if your pet stopped breathing or if your pet's heart stopped, depending, different phrasing for different people. And would you want us to try to resuscitate them? And yeah, for a lot of owners that can be very emotional. I had one client when I worked where my technician, it was a hit by car, and they brought the dog in, younger, like late teens, early 20s, and my technician asked her about CPR orders, and she hit the ground sobbing and was inconsolable, and we could not talk to her for 10 minutes. And it's like, well, I guess we're doing CPR because I don't have other orders. But then also when we have the time, we may be getting that CPR DNR order the minute they walk in the door. But then as soon as we have time to talk to them, I'll revisit that conversation, because I think a lot of people default to do everything's, CPR, but they don't understand. And I don't always have time to explain right the minute they're coming in, is that if we get to the point that we're doing CPR, the likelihood of your pet, like if we get it back, the likelihood of your pet doing well after that is pretty slim. And so sometimes it is having, like making sure you have a trusted technician who can go and have a little bit more of an in-depth conversation with your client about that decision, especially if they're on the fence. I had a patient that came in, and I forget what the case was, but it came in DOA. The owner, we did CPR because the owner wanted it. We got it back. And then when we started, then as I talked to the owner about all of the things that we were going to potentially be dealing with, and the fact that it would need to go to the specialty hospital and things, she's like, well, I can't do that. And we ended up euthanizing. And it's like, how hard of that is that on your team, and the client? It's a lot to put the pet's body through. And so, trying to get that information, but in a way that we're communicating, and we want to be compassionate about it, but say, unfortunately, we just, we want to let you know that CPR is not often very successful. And when it is, you're going to, here are the things that, that you're going to need to be prepared for. And also setting, as I said earlier, setting the expectation of, are we going to need to transfer this pet? Is, if this is a blocked cat, and we don't hospitalize overnight, our recommendation is going to be to transfer. Now, if that's not feasible, then we can explore, is this one that we can treat as an outpatient where we can unblock and send them home? But we have to kind of set those expectations early. And if the client calls in before they are on their way, or like they're on their way, or they call in to say, hey, my dog just ate something, or my dog's having trouble breathing, what do I do? I'll often, if it's something I think we can handle, I will have my staff tell the client, like, yep, come on up, but this is our limit. Like, we will tell them our limitation. We may end up recommending that you go elsewhere. So if you don't want to have to double pay an exam fee, you may be better off just going to the ER. And so setting expectations with clients ahead of time, it can go a long way.
Yeah, I think that's a very important point as well, and I do that all the time, and usually I get on the phone myself, and because I want my clients to know, I'm not refusing to see you. You can absolutely come. I will absolutely, assess your patient. But what you're saying right now sounds to me like it's something that is going to require more care than I'm capable of giving. And if you want to bypass me, that's totally okay. And just giving them that option. And I find most of my clients really appreciate that, So sometimes people get a little snippy about it, but most of the time I feel like they appreciate that honesty. Cost conversations, they're always hard, always. During emergencies, when emotions are high, they're even harder. So how do we, what kind of language help keep those discussions surrounding, particularly surrounding cost of care, very clear while still being compassionate.
I mean, I think one of the biggest tips that I have is to really lead with the care conversation and then the cost. So you, like, think about if your pet has just been hit by a car and you're carrying it into the clinic. And in most clinics, that pet is going to be whisked away from you back to behind a closed door that you can't see them. And the receptionist looks at you and says, it's going to be $500 to stabilize your pet. Like, how does that land? Whereas if they say, right now our doctor and technicians are working, are working on stabilizing your pet. Hopefully you know their name, but if, but they're stabilizing Fluffy. As soon as we have an update, we will let you know. We do like to, let people know it can cost up to $500 for that initial care and assessment. That just, it doesn't take that much longer to say that. And it lands significantly different because then you're leading with that care conversation. And so, and people do need to understand like what it is that you're doing. And especially when they're not seeing what you're doing, you really want to make sure that they're understanding the value of what you're offering. Now, at the same time, if I have a pet that's doing really poorly, I may not I may not be able to be away from them for very long to have lengthy conversations with the owners. And so sometimes I may not be able to go into full detail about, what the IV fluids are doing and, what we're accomplishing with the different things that we're doing in the moment. It may be, hey, I need you to approve this estimate of $1,000. And, hopefully I have technician staff. I mean, I do, but hopefully you in your practices have technician staff who are comfortable enough to kind of explain some of that care conversation to clients.
Yeah. We already talked quite a bit about talking to the client about potential transfer. I'm really curious. You've been on both sides of the phone, on the ER receiving side as well as on the GP transferring side. So what information do you think is most helpful for the clinicians, at the receiving facility when like me, when I call to transfer or to, or those stabilization questions like you were saying?
Yeah. Yeah. I mean, I think like one is just, just give them the signalment, what's going on, what you've done so far. Like I said, I always like to ask, like, is there another, is there something else you want me to do before I send them? Or is it better like, hey, let's just get them out of my building and into yours? Yeah, there are some of those cases, in the GP setting where I'm like, I want this pet out of my building as quickly as it can. And sometimes I tell owners like, look, your pet is, your pet could become very critical. We're not there yet, but you've got an hour to get to the specialty hospital. I want you to start driving now if you're willing to go. The dog that I mentioned yesterday, they were actually on their way out the door to go to the specialty hospital and the dog became apneic. Like I heard the client scream in the parking lot. And they ran back inside and, we immediately intubated. And then I'm like, I don't know what to do now. I've never had like, she doesn't want to stop. And so that way, I'd already called and talked to the ER once to say, hey, I'm sending this patient, here's the drugs I've given so far. What else would you want me to give? And, so I called them back and I said, hey, situation's changed. Like, what do I do next? And that, and so I was probably that dog was in our hospital for about 6 hours yesterday, before we got it stable enough to transfer to the ER. And I probably was on the phone with the criticalist like once an hour. Like I think the whole ER or the whole reception team at the ER like just knew like when I like knew, hey, calling for Dr. Tori again.
It's me again.
Yeah. And so, and she was wonderful, and she, I know that there sometimes can be some friction between GP and ER. But I think just, being honest and saying, this is what I've done. And is there anything else that you recommend I do? And they might say, hey, give XYZ drug. And you're like, I don't have that. So, sometimes we don't have the medication. Like I had a chocolate toxicity dog that we had been monitoring that started to become symptomatic. And when I called the ER, they're like, give propanolol. And I'm like, yep, don't have that. Not something we keep in stock here. And so it was like, okay, well then just send them. Because sometimes it is better to just get them on their way. But yeah, with that respiratory distress case, she's like, you can't send that dog right now. It's, I'm gonna walk you through what to do, but it's on you and your team to do it right now. And so, sometimes it is, but it is just having those honest conversations and then just making sure we send records. And I send them like 6 different ways. Like I will send a paper copy with the client, disc of the x-rays. I will send it through the portal. I will email it. I will fax it because I don't trust technology. And so, especially if I'm sending them at the end of the day and we're going to be closed, like I really don't want my clients to have to spend money repeating diagnostics that I've already done simply because the ER can't get access to that information.
Yep. Yeah. And I think it comes down to what kind of a clinician you are and what kind of relationship you have with the ER. I'll oftentimes give them my cell phone number too, because for that same reason, I'm like, if they get there and you have questions, we're closed. We have no backline. You can't get a hold of me. And not everybody may be comfortable doing that, but if you are, those communication, those open communication lines, I think are really important. You talked about in the article the importance of building these relationships with your nearby ER clinics before you're in this situation. But what does that really look like? Like, what does that outreach look like in practice?
Yeah, I mean, I think the first step is just having a conversation and saying like, hey, especially maybe there's a new hospital that's opened, reach out to them and say, hey, we may be sending clients to you. We just want to know kind of what your general flow is. Do you want us to call and tell you a client is coming, or do you just want us to send an email? Do you want one of our doctors to talk to one of your doctors, or is just a quick heads up call from the technician, hey, we're sending this, you know, like just finding out what their preferences are there, and then finding out like how do they like to get records? Do they have a portal that online that you need to sign up for, or can we just email it? So just finding out like some of just those basic communication preferences I think is really important. And then also I think just asking the question of, hey, if I've got a pet that is really critical or is beyond what I'm used to handling, are you okay with me calling and just getting some advice on how to handle them? I understand that you're busy and, you may not always have time to get on the phone, but if you're available, is that something you're okay? Because we've got a few different specialty hospitals in our area and I know which ones I'm going to call for which different things because I've developed those relationships with some of those specialists. And so, I know, hey, if I need a cardiologist, I'm going to call this hospital. And if I need, the critical care department, I'm going to call this hospital. And some of that's shaped by past experiences and their willingness to get on the phone. And sometimes I'll also, say to, just ask them, what, do you like us to do diagnostics before we send them? Or would you rather just do them all? Like, are you going to repeat x-rays? Even if I do them in my hospital, are you just going to repeat them regardless? Then I don't want to spend my clients' money on x-rays with me. Or, I've had some where, we've been referring for like a suspected foreign body and, they'll say, hey, if you want to run blood work before you send them, that'll save the client some money. And so just having those conversations and then also having some general idea of pricing. Because I do think that's a really important conversation for us to have before we send the client. Because working in the ER, it broke my heart when I would have transfers and the client came in and they had no expectation of cost and they get to me and we have the conversation. They end up saying like, you know what, no, I can't hospitalize my pet or I can't do this surgery, and ending up euthanizing with someone that they don't know
No.
instead of with their home team. Now having been on both sides, yes, I as the GP doctor have had the full conversation. I document that I had the full conversation and the client gets the ER and they're like, they never told us that. it happens. And so, on both sides, I think we need to give each other the benefit of the doubt a little bit of like, clients, like you said, it's an emotional time for clients. And so they might not hear everything that we said. They're just focused on, okay, you just said that if my dog isn't hospitalized, that I need to euthanize, and that's where they stopped listening. And they didn't hear when you said, hey, the specialty hospital said it's going to be $3,000 to $5,000. And so making sure that, we document the conversations, and I'll usually let let the ER know. And also if there's something special about the client, like, if there's a history that they need to know of, like, hey, this dog belonged to their spouse who died last week. If we have that information, I think especially if it's something that's going to affect how the pet is managed, I think that ER, let them know, give them that heads up.
Yeah, I think I always approach that as like, if it's something that I would have wanted to know, I
Mm-hmm.
want to make sure that I'm telling it to someone else, Um, what would you say to clinicians who feel self-conscious about reaching out, to their local ER, to the local specialist?
I mean, I would say like a lot of the specialty hospitals now have staff members who are specifically there to coordinate referrals. So like if you're nervous about reaching out directly to a doctor, like just call and ask, like, do you have a referral coordinator that we could talk to? Like that's literally their job, is to build relationships with the hospitals in the area. And so, starting with that, or, ask your practice manager to call and get some of that initial information of what are your preferences for communication? Are you willing to discuss cases over the phone? How do you want us to notify you of cases coming in? And so I think some of it is like, I mean, we have so many difficult conversations with clients every day. We shouldn't be scared of calling our colleagues to talk about cases.
Yeah. Let's jump back to, our home clinic. When do you think is it appropriate to reschedule those appointments? You and I both talked about how oftentimes we're solo in clinic. How do you frame that conversation with your, other clients that maybe have been waiting weeks to get their, wellness appointment,
Mhm.
and still maintain that trust in the practice?
Yeah. So, I mean, some of it depends on what we're getting into. So, if hey, I've got to head into an emergency surgery, like I physically will not be available to like see your pet. I've tried. I cannot be in two places at once. I think it's calling, and I think I think it's better to be proactive and call them earlier. And it may even just be a heads up of, hey, calling from the vet clinic to let you know that our doctor, got pulled into an emergency surgery. Your appointment's in 2 hours. We're hopeful that we'll be done by then, but we wanted to let you know there may be a little bit of an extra wait today because of that. Or if you would rather reschedule to a different day, let me see, we're going to prioritize getting you in. So I think that's a lot of times how I approach it, is like, we're calling to give you a heads up, and we're going to give you we know this is inconvenient, and we're going to give you the option of rescheduling. Sometimes you already have clients in the building, or you're not able to get a hold of clients, and then it is just when they're like when they arrive at the clinic, hey, our doctor is dealing with an emergency right now. She'll be with you as quickly as she can. What we did yesterday, while like myself and one of my technicians were working on manually ventilating and monitoring this patient, I had several appointments. And my colleague was in the building, but she was in a dental procedure, so she couldn't go see appointments right away. And so we asked clients, we said, like, we know this isn't ideal, but would you be okay with us taking your pet out of the exam room to the treatment area? The doctor will do her exam there, and then, a technician will come in and talk to you, or, maybe I can pop in for a minute or two. And when we explained what was going on, she really needs to be close to this patient. She can't, I can't be far away from him. Clients were very understanding of that. And we're like, yeah, absolutely. That's fine. Um, so, and then once my colleague got out of dental, she was able to, to take over in appointments. But I find most clients, if you're upfront with them of, we have an emergency, our doctor, like that, our doctor has to focus on that right now. Here's what this means for you. Most clients are pretty understanding, because if their pet was the one having the emergency, they would want your focus on them. And that's what a lot of the clients will say. Like I had one where, I did pop my head into the room and I'm like, hey, everything looks great. This is my recommendation. And the clients were like, okay, great. We don't want to take up any more of your time. We'll call if we have questions. And so I'm an eternal optimist. So I tend to, believe everybody's going to be, good. And so, but the vast majority of clients truly are understanding. We just don't put them in a room and leave them sitting there for an hour where they think you've forgotten about them.
Yep. Agree 100%. And I think there's always kind of a tendency to remember the people that got upset or
Mm-hmm.
complained, and that's not the way we should be thinking about it. Because my experience is just like yours. Most people absolutely say that. If it was my pet, I would want you to give all your attention and resources to them. I'll reschedule. I'll wait. Everything's fine. But keeping them updated is so important.
Mm-hmm.
So,
Yeah.
oh. All right. Finally, what do you think the biggest misconception about handling emergencies in general practice is? And what do you think you would like clinicians to understand instead?
Ooh. I mean, I think it's the sometimes you get in. I've seen some of my colleagues get into the mindset of like, I can't do this. I can't handle the sick pet. I can't do the emergency surgery. And so I think the biggest thing is just, you know, we can do it a lot of times. Or at least get things started. I keep talking about the dog from yesterday. I did not think that we got the dog alive out of the clinic. And I knew last night that it made it alive to the specialty hospital. And I was not optimistic that this dog was going to survive. And we got a call this morning that he's being discharged today. So, like, yeah, no, I had never had to manually ventilate a patient before in respiratory distress. The idea of anesthetizing a patient that was actively in respiratory distress, I'm like, this is terrifying. But I had the support of the criticalist who's like, this is what you're going to do. This is the drugs you're going to use. Call me at this point. And I was upfront with the client. I said, like, I don't know if this will work, but if you want to keep going, this is our option. And so I think it really is just clear communication, be willing to try, but at the same time, don't put yourself, don't say, oh yeah, I'm going to do that surgery that I've never done before with no prep and dive in. Like, don't put yourself into a situation where you're really opening yourself up to risk. But at the same time, be willing to try. Does that
Yeah.
make sense?
No, it does. It makes perfect sense. Absolutely, because if you don't try, then we know the outcome.
Yeah.
so,
Yeah.
so
And it's being honest with the client of,
mhm,
hey, if I try this, your pet might die. If I
mhm.
don't try this, your pet will die.
Yeah,
So those are your choices.
yeah, yeah. That's sometimes where we are. So,
And again, it is different if you have the ER specialty hospital 5 minutes away
mhm,
versus, 30 minutes, an hour away. And I think too, sometimes those of us who have practiced away from specialty hospitals, I think sometimes we're forced into those situations of like, hey, it's me.
it's me or
And
nothing.
so,
Yep.
right. It doesn't mean we're always comfortable with it, but, it's kind of, there definitely are some geographical differences in comfort levels around it.
Yeah. Well, this was a wonderful conversation. I encourage everybody at home to also check out the article, read through those tips and, maybe implement some of those strategies to kind of prepare beforehand so that you feel more comfortable when the emergencies walk in. Dr. Kate, you said you have listened to the podcast before, so you may know about our little rapid fire questions at the end. Do you want to play?
Let's go. I did not prepare for them, but I do remember that they exist.
They exist, and you wouldn't have had, you can't prepare for them. That's the fun of it. All right. First question. Would you rather work an overnight relief? Oh, you said you were superstitious, so this is a good one. Would you rather work an overnight relief shift in an emergency clinic during a full moon or a major holiday?
Ooh. Major holiday.
Major holiday. Okay. Would you rather have perfect client compliance or perfect patient cooperation?
Patient cooperation.
Oh, sweet babies. We'll deal with the people that don't follow your recommendations.
I can only do so much for the patient compliance.
Okay. All right. Would you rather continue practicing but no longer mentor other veterinarians, or mentor other vets full time but not practice anymore?
Ow, that one hurts. I probably would go mentoring because you can still kind of live vicariously through practice that way.
Yeah, that's good. I figured that was what you would say. Okay. Would you rather see 15 sick appointments with no records or 1/3 opinion with 100 pages of records to go through?
Absolutely the 15 sick appointments.
We're not going to read through 100 pages of records. Okay. All right. Last question. Important question. Do you think injectable meropitant smells like Band-Aids or like gasoline?
So I actually have a really terrible sense of smell. So
that's good in this profession.
Yeah, it's a great benefit. But I know, I think it smells weird, but I don't think I've ever, I don't know that I know what it smells like.
Placed it. I think it smells like Band-Aids personally. So this is always a big discussion.
I definitely don't think it smells like gasoline. So I guess okay. Band-Aids.
Good. Excellent. I don't know where people come up with that one. All right. That was it. It wasn't bad, right?
No, that's fun.
Okay. Great. Well, thank you again for coming on the show. We really enjoyed having you. We would love to have you back. And everybody at home, thanks so much for listening. We hope you'll join us in the future for more conversations. Thank you for listening to Clinicians Brief the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.